So I'm here with another series of 30 questions in 30 minutes. Today we'll cover two small topics together, PPH and Puerperium. Since lesser number of questions have been asked, I have compiled them together. So we'll cover these two today. Let's start with PPH. So what is definition? In INICET 2021, a question was asked where there was one option was definition, one was classification, and one was general management. So we need to know about all of them. What is definition? Blood loss of more than 500 ml in normal delivery and more than 1 liter in cesarean is PPH. The most common cause of PPH is atonic. Now, I'm not going to revise the causes of PPH. I know you all must be knowing 4 T's. What are those? Tone, tissue, trauma, thrombin. You all know the most common cause is tone. So anything which causes atonicity can cause PPH. Okay. Now, what is the classification? It has been classified into two types. Based on duration, it can be primary PPH. One which occurs within 24 hours is primary PPH. Secondary PPH is 24 hours to 12 weeks. Remember, it is not 6 weeks, it is 12 weeks. Then another way of classification is based on the amount of blood loss. So minor is if the blood loss is 500 ml to 1 liter. Anything more than 1 liter is major. Now major is again divided into moderate and severe. Severe means more than 2 liter. Okay, so minor means less than 1 liter, major means more than 1 liter, more than 2 liter is severe blood loss, right? So let's talk of the management. Any management of any emergency that has happened is it starts with general management first. Management of PPH is also divided into general management, followed by medical management, and then the surgical management. So general management, first step is call for help. Always, any catastrophe happens, cord prolapse happen, abruption happen, PPH happens, first step is call for help. Then is crystalloids. So till you have got the blood, the fluid resuscitation of almost 3.5 liter of warm fluid is very much required in a patient with severe blood loss. So these 3.5 liter fluid you have to resuscitate. Initial 2 liters has to be crystalloid. You do not start with colloid because in many people, colloid can cause the anaphylactic reaction. That is why you have to start with crystalloids, infuse almost 2 liter of crystalloids followed by colloids. Okay, so this was the another option in INICET 2021 question. Then assess the blood loss and arrange for blood and blood products. In medical management, you start with uterotonic drugs. So first drug which you use is oxytocin. So oxytocin in treatment of PPH is given as infusion. Okay, you give infusion 20 units in 1 liter fluid and that infusion is used for treatment. Remember, for prophylaxis in management of third step, we're using IM and IV infusion both, and IV bolus, slow IV bolus is given in cesarean. Okay, but in treatment of PPH, the route of oxytocin which you can use is IV infusion. Another very commonly asked drug is carbetocin. Carbetocin is a long-acting oxytocin analog. We'll discuss this in detail because the question has been asked on carbetocin. Next is methergin, misoprost, carboprost. On all of them, the questions have been asked. The medical management phase. Next step is the surgical methods. But before surgical method, you try certain conservative methods which are basically to tamponade and massage. We'll read each of them very fast. We'll cover them fast. Okay. So first start with medical management. First is oxytocin, also called as pitocin, which is our drug of choice for both the prophylaxis and treatment of PPH, given as IV infusion in treatment. Never given IV bolus because one other side effect is water intoxication that can occur with oxytocin. So strict monitoring is given when you are giving somebody oxytocin. Next is ergot alkaloids, that too methergin. So methergin is the dose is 0.2 milligram IM. It is given IM. It can be repeated in 2 to 4 hours. Maximum doses you can give is 5 doses. It has not been asked, but you should know that maximum doses of ergometrin you can give is 5 doses. It's a very strong vasoconstrictor, hence cannot use in hypertension, preeclampsia, asthma. Asthma we have to discuss right now. Okay. Misoprost is PGE1. The treatment dose of misoprost is 800 micrograms sublingual. Okay, whereas the prophylactic dose, both of the questions have been asked. The prophylactic dose is 600 mg oral. 600 mcg oral is the prophylaxis dose of misoprost, and the question has been asked in AIMS. The dose of misoprost both for prophylaxis of PPH and treatment. So you should know this dose, right? After misoprost, you have carboprost, which is PGF2 alpha. Now PGF2 alpha, the dose of carboprost has been asked in NEET 2019. In NEET 2019, they asked the maximum dose of carboprost that can be given. Okay, so dose is 0.25 milligram IM. You can repeat it every 15 minutes, but how many times you can repeat it? Till 8 doses. So only 8 doses can be given of carboprost. So maximum dose that can be given is 2 milligram. That was the question asked. Okay, cannot be given in asthma, right? Okay. Next is carbetocin. Carbetocin. Now, what is carbetocin? It's a long-acting agonist, long-acting analog of oxytocin. Now, recently it has been used very widely in cesarean. So, it has half-life almost 5 to 10 times that of oxytocin. So, it acts very fast and single-dose injection act as long as कि आप 16 hours confusion दे रहे हो. So it acts that long. So single injection has given very good response, especially used in cesarean for treatment of PPH. So the question that has been asked on carbetocin was in INICET 2021. So the dose was asked. So the dose is, can be given both IM and IV. It is 100 microgram bolus given within 2 minutes. So that is the dose. So given within 2 minutes. Not can be. So the dose is 100 microgram IM or IV given within 2 minutes. That was the question asked. But it cannot be used when patient has history of preeclampsia and seizures, and if patient has been given general anesthesia, then the carbetocin is avoided. Okay, so you should know all these drugs. The questions have been asked. Another question that was asked this year was in NEET 2023 was the which prostaglandins can be given in asthma. So very important that I have discussed in my lectures also, which prostaglandins can be given in asthma. So there are 3 things. One, prostaglandins that can be easily given with no problem in asthma is mesoprost. Okay, mesoprost is very safe in asthma. Then which prostaglandin you give, but you have to be cautious when patient has got asthma, PGE2. Dinoproston is drug for what? For induction of labor. So dinoproston can be used in asthma patient, but you have to maintain the vigilance. Drugs which cannot be used is carboprost, PGF2 alpha. Besides that, methergin can also not be used at all in case the patient has asthma. So this is very important. How to use prostaglandins in asthma asked in NEET 2023 this year. Now, so suppose your drugs have not worked. Okay, now your drugs have not worked. Now next comes the mechanical methods. Mechanical methods are basically 2, and these are uterine massage and balloon tamponade. If we talk about uterine massage, see, these conservative measures are used when your medical management has not worked. But massage is something, imagine yourself in labor room, a patient has underwent PPH. Before giving oxytocin, you're standing there, you can easily start the massage. So uterine massage, though it's a conservative measure, it is started as soon as the PPH is diagnosed, along with oxytocin. So if the sequence of PPH management is asked, then after general management, your first step, even before oxytocin, is massage. Okay, as soon as you see it is atonic, uterine massage is your first step along with oxytocin. Okay, so it's a temporary measure and it can control the PPH very well. No, not done in prevention. Why I have specially mentioned this, that it is not done in prevention because the active management of third stage of labor, which is done in every patient to prevent PPH, massage is not an option in that. Uterine tone assessment is there. You will assess the tone, and if it is getting atonic, then you will do massage. So massage is not for prophylaxis, right? Right. Another conservative measure is balloon tamponade. So Bakri balloon basically commonly used is for tamponading. You fill the Foley catheter, or you can use Foley catheter also. So you fill the balloon with 300 to 500 ml of saline. You keep it there for 24 hours. It provides tamponade and control the PPH. So these 2 are the conservative measures. Now, if these conservative measures do not work, then you have to go for surgical management. But before surgical management, before you take the patient to the OT, you need to do certain temporary measures called as temporizing measures. The aim of temporary measures is they will not control PPH. They will just, for the time being, direct all the blood which is going into pelvis towards the heart. That's what the temporary measures do. 3 temporary measures: bimanual compression, like this, aortic compression just above the umbilicus towards left, and anti-shock garment, non-pneumatic anti-shock garment. These 3 are used, then patient is either being transferred to a better facility or to OT. These are 3 temporary measures. Next comes the surgical management. Now, if none of the measure helps you, your next step is the surgical management. Your medical management has not worked, your conservative management has not worked. Now comes surgical management. So surgical management, sequence wise, what you have to do is following: compression sutures first, also called as brace sutures, selective vessel ligation, uterine artery embolization, and hysterectomy. Okay, so compression sutures, they are also called as brace sutures. What do? You basically with the Vicryl try to compress the uterine anterior and posterior wall together so that PPH can be controlled. They are of three types: B-Lynch, Heyman and Cho sutures with success rate of almost 80 to 100%. Next step, if this doesn't work, is selective vessel ligation. Why selective? Because sequence wise you ligate vessels individually. Okay, so you ligate the uterine vessel. If it doesn't work, then you go to ovarian vessel. So that is why it is called as selective vessel ligation. Now the question has been asked in NEET 2021 that what is the order of sequence of ligating the vessels. First you will ligate the uterine vessel. This is, so first you will ligate the uterine vessel. Then if it doesn't work, you will ligate the ovarian vessel here. And if it doesn't work, you will ligate the internal iliac artery. Okay, that is the sequence. You are not ligating pudendal vein, you are not ligating obturator, not external iliac. You are ligating internal iliac in the last. So that was the question. What is the sequence? So when you are like uterine and internal iliac. Now, when you are ligating internal iliac, you have to ligate it 5 centimeter distal from the bifurcation so that you do not end up ligating external iliac. Okay, that too when the posterior division has been given. Can you see this is the posterior division? So you will ligate internal iliac artery after the posterior division has been given 5 centimeter distal from the bifurcation. You should know that. Now, if the vessel ligation is not also working, then you will go for uterine artery embolization, in which through femoral artery you will enter the external iliac vessel, then internal iliac, finally the uterine artery. Using polyvinyl alcohol particles, it's an interventional radiological procedure. You will do the embolize the uterine artery. Either you can see the bleeding vessel. If you cannot, you will embolize both the uterine vessels, right? So this was all about Puerperium. We discussed the definition which has been asked, then the management, and then the step-by-step management that has to be done, which have been asked in PPH. Your next topic we will cover today is Puerperium. So in Puerperium, not many questions have been asked. From the general puerperial changes, 2 questions have been asked. First has been asked on uterine involution. So on uterine involution, NEET 2021 question was asked, what is the speed of uterine involution? So exact question was, patient is day 2 postpartum, where the uterine fundus will lie. That was the question. So see, uterine after delivery, uterus is of 1 kg. Right? After 1 week, it reduces to 500 grams. And after 3 weeks, it reduces to 300 grams. Okay? So after 2 weeks. So after 2 weeks, it becomes a intrapelvic organ. And the involution of uterus is completed by 4 weeks. Remember, it is not 6 weeks as given in Datta. It is 4 weeks. At 4 weeks, uterine involution is complete. Okay? Now, what is the sequence in which fundus level is descended? You should know that. So immediately after delivery, the fundus is at upper border of the umbilicus, almost at 24 weeks level. Here it is. And it stays there for 24 hours. So it will stay there for whole 1 day. Second day, it will come 1.25 centimeter below umbilicus. That is half inch. So half inch below umbilicus, it will go per day. So if you are palpating on day 2, it will be 1 finger below umbilicus, not 2. If you are palpating on 3rd day, it will be 2 finger below umbilicus. Okay, because for 24 hours it was stagnant, right? So this was the question, where the fundus will be on day 2 postpartum. So it will be 1 finger below fundus. So that was the question asked. Now, another question that has been asked was in INICET 2021 on that intake of which of these following nutrient increases in lactation compared to pregnancy. So basically they wanted to know that whether you understand that which nutrient you have to supplement during lactation much more than that of a pregnant woman. So this is ICMR 2020 guidelines. So ICMR changed little, made little changes in their RDA values of these nutrients, which you should know. So they are different from earlier guideline of 2010. You might find different guidelines in 2010 table. 2020 table is the recent one. If we talk about calorie, whatever the calorie of RDA for an adult woman, you add 350 kilocalorie a day when the woman is pregnant. And it increases to 600 in 6 months post-delivery and to 520 after 6 months. So calorie requirement in lactation increase, that too in first 6 months. It is additional 600 kilocalorie per day. Okay, so it increases. What about protein? The protein requirement is, according to new RDA, is not 1 gram per kg per day. The protein requirement for an average man and women, I'm saying 0.83 gram per kg per day. For an average Indian man and woman, this is the protein requirement. Okay, 1 gram per kg per day is the requirement for vegetarian man and female. Okay, so this has been updated in 2020 guidelines. It is 0.3 kg per day. So you should remember that. Now, additional 9.5 grams of protein is needed in first trimester. In second trimester, significantly high amount of protein is needed because that is the time in the third trimester when the fetus will be gaining weight. Now fetus will need high amount of protein. That is why you need 22 grams of extra protein in the second half of pregnancy. It reduces in lactation to 16.9, further to 13.2 in lactation. First 6 months, and this is after 6 months. So protein supplement is definitely higher in lactation compared to a non-pregnant woman. But compared to a pregnant woman, the protein supplement needed in lactation is less. Whereas calorie in a lactating woman is high. Calcium. That was the question which was asked. The options given, the calcium was answer. Calcium supplement which is needed in everyone, be it pregnant or non-pregnant, is 1000 milligram a day. And it has to be increased to 1.2 gram a day in lactation. In lactation, 200 milligram requirement is more. So they have to be supplemented with calcium. Okay, so calcium requirement is 1 gram per day for pregnant and non-pregnant both. In lactation, it is 1.2 grams. Okay, iodine requirement, because of fortification, iodine requirement is less. 150 mcg in every woman, men and women. 250 mcg in pregnancy and lactation both. There is no change between pregnancy and lactation. What about folate? So folate need is obviously much higher in pregnancy, but in lactation it is not very high. So you need extra 300 mcg of folate in pregnancy, but lactation you need only 100 mcg. So you need more in pregnancy. What about vitamin D? Vitamin D requirement is 600 international units for everyone. Be it pregnant, non-pregnant, men, women. It is 600 international units for everyone. Okay, it's universal. Now, if we talk about which vitamins requirement increase in lactation. If I talk about lactation, we have seen that calorie requirement is more in lactation. Calcium requirement is more in lactation. Now I'm specifically talking about which vitamins, if asked, though they were not in the question, they are very, because they are minor nutrients, but micronutrients, but you have to know that among which of these demand is more in lactation. Vitamin C demand is more in lactation. Vitamin B6, niacin, vitamin B12. All these four, in all these four, the demand in lactation is higher compared to pregnancy. Vitamin C, B6, niacin and vitamin B12. Majorly you have to remember is calcium and calorie requirement, which is higher. Okay. What about vitamin A? That was the question, and many of you must have marked vitamin A because 2010 table of ICMR showed that vitamin A requirement becomes more in lactation. But the recent table does not show that. It shows that vitamin A requirement is 900 mcg per day for an adult woman, non-pregnant, for pregnant, for lactation. There might be little change of 850 to 900, but no major change. Okay. So vitamin A amount, RDA value does not change. Okay. I hope you get it now. So this was about general puerperium. Now puerperal complications, few puerperal complications have been asked. Let's start with puerperal fever. Puerperal fever, also called as childbed fever, and when the temperature is more than 38 degrees Celsius to 100.4 during first 6 weeks after delivery, that is puerperal fever. Now causes can be any. Okay, but the most common cause is genital tract infection. Genital tract infection specifically is called as puerperal sepsis. So puerperal sepsis, when it is said, it is genital tract infection. Okay, puerperal fever can include any of the genital tract infection or non-genital infection, right? Okay, so how does WHO define puerperal sepsis? It defined it as genital tract infection from the onset of rupture of membrane or labor till 42 days postpartum is puerperal sepsis, infection of genital tract. Patient will have any two of the following: fever or pelvic pain or abnormal vaginal discharge or abnormal uterine involution. All these will be there, any two of them. Okay, that is sepsis. Now, the question has been asked basically on pelvic thrombophlebitis in INICET. So, what is pelvic thrombophlebitis? It's a thromboembolic complications of postpartum. When the endometritis, or you say the puerperal sepsis of uterine endometrium, if it is not resolved well, what it leads to? It leads to pelvic vessel thrombosis. Thrombosis and inflammation of pelvic vessel that can extend to iliac vessels also. That is pelvic thrombophlebitis. It's a sequelae of uterine endometritis. If it is untreatable, it will lead to this. How will you diagnose it? A patient presents to you with fever, genital tract infection, you give her antibiotics, but she doesn't resolve. So fever does not resolve even when you have given full antibiotic course. Patient will have abdominal pain, and on palpation you can feel tender vessels, thick tender vessels you can feel, since it's thrombophlebitis of those vessels. Okay, tender cord-like masses you can feel in lower abdomen. How will you diagnose? You will diagnose by CT scan or MRI. Many times on MRI and CT scan, you will not find the thrombus, but on symptoms, you can very well treat. It's a diagnosis of exclusion. Once you have excluded all other causes of fever, urine infection, respiratory infection, then you think of thrombophlebitis. The treatment was asked in INICET. The treatment is antibiotics plus low molecular weight heparin. You do not do thrombolysis or anything like that. You do low molecular weight heparin and antibiotics together. Okay. This complication was asked in the question. Another puerperal complication which was asked in exams was breast complications. So breast complications has been asked twice in NEET. So before discussing breast complications, two important stuff about breastfeeding I want to discuss, though not asked but can be asked anytime. I want to discuss about contraindications of breastfeeding. So contraindications of breastfeeding are following: women who are on street drugs or are alcohol abuse, infant who has history of galactosemia, and mother who's on breast cancer treatment. These three. Other than that, infection. Active tuberculosis. Active tuberculosis is contraindication for breastfeeding, and one more infection, and that is herpes. Herpes infection with herpetic lesion on the nipple, on the breast, that's a contraindication for breastfeeding. So remember these 5. Okay, HIV, hepatitis B, hepatitis C. They are not a contraindication for breastfeeding. You can feed your infant even if you are HIV positive or hepatitis B positive or C positive. It's not a contraindication. Okay. Yes. Now another thing, what about the drugs secreted in breast milk? So I think this is a very important stuff which you should know about in breast milk, because that can be asked anytime. It's a very practical thing. So if you want to start some medication to a woman who's breastfeeding, what all you need to do to minimize the infant drug exposure? The drug should have short half-life, it should have poor oral absorption, and it should have poor lipid solubility, so that the infant exposure could be less. Short half-life, poor oral absorption, and low lipid solubility. And when to give? If you are giving multiple doses, you have to give after the closest feed. Once you have fed that infant, take it after the feed is complete. So you have to take it after the closest feed. If single dose is to be taken, you will take just after the longest sleep. So if your infant sleeps longest in the day, you will take it in the day once the infant is asleep. Or if you are lucky and your infant sleeps in the night, you take it in the night once the infant is asleep. So single dose is taken just after the longest infant sleep interval. Okay. Yeah. So let's discuss the breast complications that has been asked twice in NEET. So complication first is breast engorgement. So breast engorgement is as such not a major pathology. It's actually a physiological reaction. Start at day 3. So at day 3, full surge of milk secretion starts from the alveolar ducts, and your ducts become filled with the milk. As a result, there is engorgement of whole of the breast. So breast can become red and tender, but there is no fever. So there will be pain and there will be milk discharge, but there will be no fever, and it will resolve on itself. You just have to give support and cool packs and continue breastfeeding. It will get resolved on itself. That is breast engorgement. Galactocele is when single alveolar ducts get obstructed due to some mucus plug. It leads to duct obstruction, leading to a fluctuant mass. So it's not a very tender mass, it's a fluctuant mass which resolves on its own once you feed. That's galactocele. Mastitis. Mastitis is parenchymal inflammation. So it's an infection occurred through the oronasal route of infant. Okay, so it's parenchymal inflammation. Breast will be engorged and inflamed and patient will have fever. That's how mastitis present. Since it's an infection, you will give antibiotic dicloxacillin. That was the question asked. You will give dicloxacillin, you will continue breastfeeding and your fever will resolve in 48 hours, right? If your fever is not resolving in 48 hours, it means it has become more complicated, and that is breast abscess. So if your fever is not getting resolved even after 48 hours of antibiotics, it has become breast abscess. What is localized pus formation, and that is why it is not getting resolved. Antibiotic will not add this pus pocket. You need to do ultrasound guided aspiration or incision and drainage, right? So questions have been asked on mastitis, drug of choice, and management of breast abscess. Next, psychological disorders. So questions have been asked on psychological disorders of puerperium. So basically 3 types of psychological disorders are there: blues, postpartum depression, and psychosis. So in NEET 2022, the question was asked on the psychological disorder. How will you differentiate between these 3? Very easy. So features. So postpartum blue is very common. It can occur in 50 to 80% of women, and patient will have, she will be fatigued and she will be sad and she will be very tearful. Okay, but it is not persistent sadness. She will be at times sad and at times tearful. That is postpartum blues due to the stress and anxiety, and it resolves within 24 to 48 hours without treatment. That is postpartum blue. Postpartum depression, persistent low mood, persistent fatigue and tearfulness. She does not feel pleasure in any of the pleasurable activity. That is depression. You are persistently low mood and fatigued and tearful. Okay, with anhedonia, what you say, you do not feel pleasure in any of the activities. That is depression. It has 2 peaks, one occur at 2 to 4 weeks, another at 10 to 14 weeks. So it has a late presentation. If presentation is early, day 4 to day 10, and resolve on its own, that is blues. If presentation is late with depression, symptoms of depression, that is postpartum depression, and you need to give SSRI. Best drug is sertraline. Sertraline is the drug of choice. Okay. Now, if this depression is added on with hallucinations, okay, with hallucinations and delusions, then it is psychosis. Okay, psychosis also present late at 2 to 4 weeks with hallucinations and delusions will be mentioned. Patient will have mania or bipolar, right? It's an emergency. Patient will need immediate admission. Lithium might be started and valproate, even carbamazepine. Okay, so this is how you differentiate 3 of them. Last words about postpartum contraception. So guidelines for postpartum contraception, questions have been asked multiple times on this. So any lady who has delivered, no matter whether the lady had live baby or non-live baby, she's breastfeeding or not, she does not need to use contraception for 21 days. For 3 weeks, she does not need to use any contraception. The story begins after 3 weeks. What to use after 3 weeks? So after 3 weeks, if she is exclusively breastfeeding, exclusively, nothing needed till 6 months. Okay. Now, if she is not exclusively breastfeeding, intermittently feeding, okay, or if she is intermittently feeding, then you have to start something after 3 weeks. After 3 weeks, you have to start something. What all you can use? You can use, if she is feeding still, okay, she is not exclusively breastfeeding, but she is feeding. So you can use progesterone only pills, injectables, IUCDs, anything you can use, but you cannot use CHC because CHC tend to decrease the quality of breast milk. So CHC can be used only after 6 weeks. Okay. Now another lady who had an IUD delivered. So she is not breastfeeding at all. In her, after 3 weeks, you can use anything. Even the CHC can be used because she is not feeding. So CHC affecting breast milk will not bother you. Okay. So in her, DMPA, progesterone injectables, implants, progesterone pills, everything can be given. In her who is intermittently feeding, you can give progesterone related drugs but not CHC till 6 weeks. Okay, right. Now, if somebody asks you that, though I have told you nothing to be used till 21 days, but still somebody asks what can be used immediately. If a woman wants to use something immediately after delivery, you can use everything related to progesterone, implants, again, pills, injectables. You cannot use CHCs. You cannot use estrogen immediately after delivery, even if you are not planning to breastfeed. Why? Because there is high risk of thromboembolism. So you cannot use CHCs immediately after delivery. What about IUCDs? So remember, IUCDs can be immediately inserted post-delivery, that is called as post-placental, immediately inserted during the cesarean section also, and within 48 hours. So post-placental also you can insert, and within 48 hours also you can insert. Now if you have missed these 48 hours, now you cannot insert. Now you have to wait for 28 days. Okay, because now uterus is so soft and it is very prone to get perforated. So if these 48 hours have been missed, you can insert IUCDs only after a month. Okay, so this was all about Puerperium. I hope the PPH and Puerperium has been clear to you. We'll meet next time with something new. Bye-bye.